everyone. I'm Steve Walker with Fleischman-Hillard International Communications, and on behalf of bioMérieux, I'd like to welcome you to the final webinar in a series that's designed to educate clinicians and laboratorians involved in sepsis management on the role of procalcitonin. Today's webinar is going to focus on the clinical laboratory perspective and will be led by Dr. James Faix. Dr. Faix is the Section Director for Clinical Chemistry and Immunology at Stanford University Medical Center and an Associate Professor of Pathology at Stanford School of Medicine. Before joining Stanford in 2001, he served as Director of Clinical Immunology and was Associate Director of Clinical Chemistry at Beth Israel Deaconess Medical Center in Boston, and as Director of the Clinical Laboratory at Joslin Diabetes Center in Boston. Dr. Faix's research interests include markers of sepsis, myeloma, autoimmune disease, and allergy. He's active in the American Association for Clinical Chemistry, where he is currently the chair of the Clinical and Diagnostic Immunology Division, as well as a member of the 2010 Annual Meeting Organizing Committee. Dr. Faix is also involved with the College of American Pathologists, where he currently serves on the Council for Scientific Affairs, the Chemistry Resource Committee, and the Standards Committee. So for the next 30 to 35 minutes, Dr. Faix will share information about new diagnostic tools for sepsis management and how lab directors can more effectively collaborate with the clinical team to reduce mortality from the condition. He'll also address the role that laboratory managers need to play in the development of sepsis protocols at their institutions. Then following the presentation, he will welcome your questions. So with that as an introduction, I'll now turn it over to Dr. Faix to begin today's presentation.
Thanks very much, Mr. Walker, and I'm very happy to give this webinar. I'm going to go to my first slide, which is my only detailed immunology slide. So this is a slide that shows what happens in the tissue here when there's a bacterial infection. This big cell here is a macrophage, and I've labeled it as antigen-presenting cell because that's how many people refer to it in immunology, and you see it here presenting antigen to a T cell. But most of what we're going to be focused on today is how the macrophage interacts with other non-specific or innate immune cells. The macrophage is really like that robot Wall-E in the movie last year from Disney Pixar. It kind of spends its life slowly moving through the tissue, looking for junk and looking for debris to eat and remove. And most of the time it's dead cells from the self or other kinds of normal tissue debris. But if it happens to run across bacteria who have gotten there somehow, it knows that they're not the normal inhabitants of this space, thanks to a number of receptors that have evolved over time. And the class that is the most well-studied at the moment is called the toll-like receptor. And I've shown that here, this toll-like receptor on the membrane of the macrophage. And once it recognizes bacteria, it actually is a little bit activated, so it phagocytizes faster and more efficiently. It also synthesizes inflammatory cytokines, which alert other cells in the area that there's bacteria present. And these cytokines find their way into the blood, and they actually alert the whole body that there's bacteria present. Now, of course, if there's a lot of bacteria, as opposed to a little bit of bacteria, this response will be more or less modulated. And the effects of the cytokines getting into the blood include the migration of other inflammatory cells into the area. This is supposed to be a polymorphonuclear leukocyte coming in, and this is a T cell, a lymphocyte coming in. If the macrophage has some trouble with the organism, I've tried to show that here where it's not really able to dissolve the organism as well, then it also makes more specific cytokines to actually stimulate the T cells that have come in to rev up the whole process, and that will cause a lot more inflammatory cytokines made. The chief focus today is actually another molecule called procalcitonin, which is made by all of the cells in the tissue, or most of the cells in the tissue, in some unknown way when bacteria are present. And this is sort of another marker that bacteria have invaded the tissue space. Procalcitonin also gets into the blood. We're not sure if it does anything similar to the inflammatory cytokines, but it's certainly a very good marker when you're looking at blood samples that there's some bacterial infection somewhere in the patient. So I'm going to go to the next slide and just show you, this is a cartoon that I made just basically showing the difference in the time course of the presence in serum or blood of these two different types of molecules. The cytokines These are the inflammatory cytokines, interleukin-1, tumor necrosis factor, and IL-6. They're the first to appear. Then procalcitonin, made by the cells in the area where the bacterial infection is, also appears. And then, even if you're not familiar with procalcitonin or these inflammatory cytokines, you've probably heard and are familiar with CRP, C-reactive protein, which is a molecule that appears a little bit later and is also associated with bacterial infection as well as other kinds of inflammation. And the reason why it appears a little bit later is because it's actually not made in the region where the infection is. It's actually made by the liver in response to primarily IL-6. The next slide shows that C-reactive protein is the major protein, at least in terms of its increase over baseline, of all the proteins that constitute the so-called acute phase reactants. These are proteins that the liver makes in response to the presence of bacteria or other stimulus of inflammation. And C-reactive protein has been well studied both in the context of making the diagnosis of infectious disease as well as diagnosing and monitoring other inflammatory disorders. So this slide basically shows, it's a receiver-operator curve. I think most people in the laboratory are familiar with this. It shows the performance of an assay in terms of making a diagnosis or detecting something based on different cutoff levels. And on the y-axis is the sensitivity of the assay, how well it picks up everybody who has the disease. And on the x-axis is the specificity, so that if a test is really good, it's up here in the upper left-hand corner. It picks up almost all the people that have the disease and doesn't really call anyone without the disease a false positive. And this is a picture from a meta-analysis that was done of as many studies as the investigators could find that compared procalcitonin with CRP for the diagnosis of bacterial infection. They started with a couple hundred studies and they wound up only looking at about 10. And you can see that, at least for the diagnosis of bacterial infection, it's clear in this meta-analysis that procalcitonin is a much better test to use. And that's probably primarily because procalcitonin is actually made in the area where the bacterial infection is, and CRP is not, and also CRP is made in response to other types of inflammatory stimuli. So with that brief introduction to these two molecules and to the molecule PCT, I think we're ready for the first poll question. At your hospital, how many do you feel have physicians who have been requesting procalcitonin, and have they been requesting it frequently, occasionally, or never? So here's the results. And I think that this is actually what I would have expected, actually. Procalcitonin has been used a lot in Europe over the last 20 years, but in the United States it hasn't been used as much. And that probably reflects the fact that a majority feel that the physicians never order it, but there are a minority that have some occasional orders for procalcitonin. So we're really not talking about bacterial infection today. We're talking about sepsis, and as you'll see, we're really not talking about sepsis, we're talking about severe sepsis. Bacterial infection isn't the same thing as sepsis, and also this thing called the systemic inflammatory response syndrome is not the same thing as sepsis. This is basically a list of things that you can see here: body temperature being elevated, heart rate being elevated, respiratory rate being elevated, and white cells being elevated, or an increase in the number of bands or immature forms. These are just signs that there has been a response, a systemic response to something, and if that something is a bacterial infection or some other infection, then this syndrome is called sepsis. And sepsis is not terribly uncommon, especially when there's significantly pathogenic bacteria or other microorganism that's causing the infection. And it's also something that needs to be recognized and addressed, but particularly when this sepsis becomes very severe and you actually start to see organ dysfunction, it's actually a really critical thing to recognize and to address. And the next slide makes this point by showing you that the mortality is very different if the patient just has sepsis versus severe sepsis with organ dysfunction. This is not an insignificant mortality, having sepsis, but certainly having severe sepsis, the mortality is very, very high. This syndrome, both the sepsis form and the severe form, have been known for many, many years. But in the last decade, there have been a lot of consensus documents created to look at how hospitals take care of patients with sepsis and severe sepsis.